A warm afternoon to everyone who has joined here with the session today. It is all about osteoporosis, a silent disease which is seen in most people, but having a knowledge and understanding about it is very important. So before we talk about all the clinical discussions about it, I would like to quickly and briefly introduce about Plus Physio, as it is an AI-powered clinic management platform developed specifically for physiotherapy practices. It simplifies all the clinical operations by bringing appointment scheduling, patient management, communication, and rehabilitation tracking into a single platform. Today, Plus Physio is trusted by more than 965 clinics and managed over 51,000 appointments that are automated. It also supports 30 plus languages that has helped reduce patients' no-show by approximately 20 to 25%. Beyond technology, Plus Physio has built a strong healthcare ecosystem with a community of 1,000 plus doctors. Also, academic collaboration with Ganpati University and its integration with rehabilitation and therapy devices. Our objective is not only to digitalize the clinic, but also to improve patients' outcome through smarter clinical flows. So it's my pleasure today to introduce our speaker and our expert for today. I am honored to introduce Dr. Hriday Acharya. Dr. Acharya specializes in spine surgery, pediatric spine disorder, and minimally invasive spine surgeries with more than 8+ years of experience in advanced orthopedic and spine care. He is an MS Orthopedic Gold Medalist and has completed prestigious fellowships in Mumbai, US, and Germany. He also serves as a member of Education Resources Committee of the Scolosis Research Society and has received international training from Harvard Medical School, Children's Hospital in Philadelphia, Hospital of Sick Children in Canada, and several leading medical centers in Germany. We are privileged to have someone with such an extensive clinical expertise sharing his knowledge with us today. Thank you so much from my end. The stage is all yours, Dr. Acharya.
So first of all, I'd like to thank Plus Physio for this warm welcome and this fantastic webinar, this initiative that you have been taking. So, and it's a very great platform for all of us to meet and interact and share our knowledge. Rather than a topic discussion, lecture is more like a discussion that I expect. So let's begin.
Definitely.
So it's time that we discuss about osteoporosis and osteoporotic vertebral fractures. So starting with the case, so there was a 57-year-old lady who came to our clinic, and the history was that she was pushed by a monkey on the road, and she had some acute back pain. So this is what actually happened, and she started cribbing that I have severe pain. Her X-ray showed this fracture, and the moment she comes to me, I said that the fault is not in the monkey, but the fault is in your body. So the monkey was very happy that he was not at fault, and the woman was looking like this to me that why is he telling this even after the monkey pushed me on the floor. So this is because what we are discussing today, osteoporotic vertebral fracture. So almost 40 to 60% are only diagnosed, and the other 40% of the osteoporotic fractures are actually missed. So why they are missed? So they are missed because the pain is very similar to some normal back pain, but we need to differentiate what instability back pain comes as. There is some tenderness in the back. It could just vary from an end plate fracture, which we could see here, to a severe compression fracture. And they come with long-standing pain. And all of these pains correlate with back pains that we see in such elderly patients. So a patient that is a post-menopausal lady coming with a trivial trauma and having acute or chronic back pain, we should always have this osteoporotic back pain or osteoporotic vertebral fractures in our mind. So what next? So before we come to what next, how to manage these patients, let's come to the basics. So we all know that bone health comprises of vitamins, that is B12, D3, calcium, hormones, that's parathyroid hormones, especially estrogen in women, and proteins. So osteo means bones and porosis means porous. And it's as easy as these two bananas that we can see. So anybody in the audience could describe what the first banana and the second banana, how they expect them to be different?
the first banana is hard and the
Yes.
second one is ripe, so it can easily it's become softer.
Right. So that's what. So the first banana is like a young woman, and the second banana is like a old, mature, postmenopausal lady who has become very soft kind of thing. So that's what how we understand young bones versus old bones or osteoporotic bones. The first, so this is how the structures are. So normal bone has this kind of system that's very dense, versus an osteoporotic bone has this kind of system that's not very dense. So they are like bricks. Young bones are like bricks, versus an osteoporotic bones are like pillows that are stacked on one another. So osteoporosis again is not just calcium deficiency. Osteoporosis is more of the bone metabolism itself. And so women are affected more as compared to men. The primary reason being that the ratio is 1:2 is to 1:5. And we all know that after menopause, there is significant reduction in estrogen. And that's what actually causes rapid bone degeneration. So that's what actually causes osteoporosis. So here we see that this is a graph of bone growth. So what we see here is that initially till the age of 30, both men and women peak in their bone density. And after the age of 30, there is a gradual decline in this bone density. What is significant to notice is that after menopause, there is a rapid decline in the bone density, which is why the chances of osteoporosis after menopause in women are more, and that's why they are prone to early osteoporosis. So we see that around the age of 50 or 55, the osteoporosis set in. That does not mean that men are not prone to osteoporosis. Today, we see more and more men with back pain and early osteoporosis as well. But in men, what we expect is around the age of 70 is when osteoporosis actually is something that is causing problems and symptoms in them. So what are the symptoms? So it can range from just back and neck pain to some knee pains, joint pains, to pains in various parts of the body, and most importantly, change in posture. A lot of patients come to us telling that their postures have changed, they have some slouches there, they have some non-specific back pains that are present. So when it comes to evaluation of osteoporosis, three things are the most important thing. The first and the foremost is history taking, then it comes examination, and then the investigation. So there are a few history telltale signs that would actually help us know that why is there osteoporosis, or this is the patient that we are facing has osteoporosis. So before we go ahead, can we have a couple of history that you see in your daily practice, that when a patient with back pain, how will you define them as patients with osteoporosis? So somebody to volunteer one symptoms one by one.
Fracture without a trauma.
History.
Sorry, fracture because of trauma, yes. So other than fracture, any specific types of back pain that the patient you feel will have pain because of osteoporosis and it's not a slip disc?
Constant pain, sir. Not an
Constant
intermittent
pain.
picture.
Right. And so one more thing, constant pain. So after constant pain, what is do you feel will be the location of the pain? This is again an important thing when it comes to location, where you'll feel that this is more like an osteoporotic pain rather than something because of anything that's more like a disc or a stenotic or something else. So what do you feel will be the location of the pain?
Sir, more
So
of the mid-back pain.
exactly, yes, very nice. So most of them will
And
have
also
mid-back
the
pain.
quality of pain is more like a dull ache, not a sharp
Exactly.
stabbing pain,
Right,
but more dull.
right, right. So now when
Sir, low
just
back
taking
pain
this
and mainly calf muscles pain.
calf muscle pain, okay. So when a patient, just to take this discussion ahead, when a patient with mid-back pain comes to you and he has always had a dull aching pain and now he comes with a sharp shooting pain, severe pain, what do you suggest? What will that suggest to you clinically? I think Dr. Preeti Shah can take this further.
So if it is turned into a sharp shooting pain, then obviously first we need to see whether the bone has actually fractured, because sometimes a trivial, even like just forcing to open a window also they can have
Right.
a
Right,
fracture,
right.
osteoporotic
Right.
fracture. or sometimes then we have to then rule out also the other condition that we have in mind,
Exactly.
like
Excellent.
other
So-
red flags.
Yeah, so the first thing that is that when patient with a dull aching pain, which falls into this bracket of osteoporosis, comes to us with severe pain, that means we need to consider osteoporotic fractures in them, and that's when we go ahead. So coming back, so history becomes the most important thing. Most patients with osteoporosis come with history of they feel tired too often. So this is the most common history that comes to in my clinic, that they said that पहले मैं इतना कर सकती थी या इतना कर सकता था. I used to do my household thing. I used to take my kids or my grandson for a walk in the garden, but now I feel too tired. They feel that their capacity has turned down. कि अभी capacity नहीं रही है. पहले बहुत ज्यादा कर सकता था, पर अभी बहुत नहीं कर सकता. They want to rest and lie down every few minutes. They have pain in arms and legs. So as somebody said, that calf pain. So arms and leg pains are something that also relates with osteoporotic pains, muscle pains, and that may not be associated with some radiculopathy or some other joint pains. And as I said, change in posture. So all these are very common complaints that comes to us quite often. They could be neglected with some non-specific pain, but we need to be clear that all these signs and symptoms are because of osteoporosis, and we need to take them into consideration. So then there are times when they come with, as you said, worsening of back pain. There is pain when they get up, pain when they turn in bed, pain in any form of movement. There is more back pain as compared to leg pain. They have had history of osteoporotic fracture. So somebody who has had a toe fracture or the little finger fracture in the toe, that would mean that there is some osteoporotic fracture. The patient already has osteoporosis, and those patients are even more prone to osteoporotic vertebral fractures and difficulty in walking. So all these are red signs, red flags, and these patients need deep further evaluation. So is it just bone pains? So this becomes very important. Pain in most elderly is not just bone pain, it's bones and muscles. And we all know that osteoporosis is associated with sarcopenia, and both bones and muscles get weak. Next, it comes to how do you check? So the three important tests and investigations are bone density scan, that's BMD, X-rays, and blood test. So bone density. So bone density is a simple test like an X-ray, and it is very important that whenever you see or you order a bone density, there are three bones that are generally checked: the wrist, the hip, and the spine. So it does not mean that if somebody has a osteoporotic fracture of the hip or osteoporotic fracture of the wrist, to just check that thing. Most of the radiological centers around would actually ask that what kind of bone density do you want to do? A single joint, two joint, three joint. The most ideal thing is doing hip, spine, and wrist. And with that, the average or the worst value is what we take into consideration, because those three joints actually represent the entire body. And it's very easy to see. So something that's less than minus 2.5, and their dots in the red would mean that the patient has osteoporosis. In the green would mean normal bone, and in the yellow would mean osteopenia. But this value of minus 2.5 is very important. Wherever you see a T score or a Z score that is less than minus 2.5, that would mean that the patient has osteoporosis, and those patients need treatment for osteoporosis. Next are X-rays and MRIs. So they are not always required, but when you suspect something else, X-rays and MRIs help, like an osteoporotic fracture or something else, and knee X-rays. So this is an X-ray of a young guy, MRI of a young spine. What we see, these squares are the bones. This black putty is the disc, these white and black things. And these are the nerves, the white, black, and white, the things that's going down. Versus an old person, there are a couple of differences that we see, that here we see there are uniform white disc versus all of these discs are black and worn out. You see this small fracture here, degenerative changes here. So these are old and young MRIs, and this is what we could actually differentiate how that there is degeneration and changes in the bones that go on. Next are blood tests. So there's D3, B12, calcium, and that's something that should be evaluated at least once a year. So coming to prevention. So all these symptoms can be prevented and treated. Everyone has some kind of weakness, but may not have all kinds of symptoms. And the most important thing is most of them improve with lifestyle modification. And that's where, as a physiotherapist, you play a key role there. So why do we need to treat them and prevent them? The reason to treat osteoporosis is that 20% there are higher chances of a fracture after fall for somebody who has osteoporosis. And as I said, somebody with one fracture has almost 50% higher chance of developing a second fracture. It can be a hip fracture, a spine fracture, or the wrist fracture. And hip and spine wrist generally need to be operated or plastered. Spine is the only one that generally does not need an operation. So coming to prevention, the first is posture, the second is exercises, weight control, and nutrition. These are the four primary sub-classification where prevention of osteoporosis comes into play. So coming to exercises, so the first is there are two kinds of exercises that we actually describe. The first is endurance and the second is strength. So when it comes to endurance, it includes walking, cycling, and swimming. So why endurance? So why would you suggest somebody to start walking or cycling if they have osteoporosis? So can somebody volunteer to answer that? For somebody with a back pain or somebody with neck pain, I generally tell them to walk or cycle or swim. So why? How will that help?
But it's a
Because,
generalized
sir,
sarcopenia also.
yeah, because sir, walking is not going to harm the traumatic region. I mean,
So we are not talking about traumatic back pains. We're just talking about patient with osteoporosis. So somebody with osteoporosis, you will suggest them to walk, cycle, swim, something, some or the other way. Why?
yes.
So there is a
Because
generalized.
So first,
So there are baroreceptors on the bone. There are baroreceptors on the bone which respond
Yeah.
to the weight lifting.
okay.
That's why they get the increased bone density with exercise, whether it is cycling or something else.
Okay. Anything else?
So because while doing walking or cycling, there is a weight bearing occurring on the joints. So because of
Right.
this, please increase the osteoblast and osteoclast in the bones. That will help in
Right.
formation of new bones.
Right.
Yeah.
So that's the same thing that lower limb strengthening will also do, right?
And sir,
Yeah.
those are the aerobic exercises, walking, cycling, swimming.
Right.
So
Right.
definitely it increases the stamina and the
Exactly.
endurance
So
of the patients.
yeah, so that's where that's something that I was looking for. So there are two forms of exercises that we look at. So one are aerobic or endurance-based exercises, and one is strength-based exercises. So aerobic exercises are something that is going to improve the overall capacity of the patient or capacity of the body. And we have the spine muscles that work throughout the day. There are those fibers that are long fibers that work rather than strength. They also work for stamina. So that's where endurance comes into play. So walking, cycling, and swimming. Generally, cycling is one of the most ideal because there's not much weight there, and patient won't fall. Swimming is also something that if somebody likes to swim, that's the best thing. Then comes the strength training. As we said, strength training is important because muscle development can happen at any age, and there's no age bar when it comes to strengthening of the muscles. So strength training, you know well about how to strengthen specific groups of muscle. It generally includes functional rehabilitation, lower limb strengthening, upper limb strengthening, specifically with therabands, because as you know, when you walk, there is weight that goes down the lower limb, the baroreceptors, there's muscle regeneration in the lower limb, but what about the upper limbs? So weighted upper limb exercises actually help increase the strength in the upper limb as well. So that's why therabands, weights in the upper limb should be done. Anti-kyphotic exercises. So this becomes the most important thing when it comes to posture and exercise in osteoporotic patients. So anti-kyphotic means extension-based exercises, postural training, all this is important. The primary reason because life is a kyphosing event. So as and when you grow, you tend to fall forwards, and so your muscles. So you tend to kyphos, and there are all efforts you need to do to keep yourself straight. So there have been researches, and this is something that has been proven that a multi-component exercise regime is something that is always going to help any patients with osteoporosis, osteoporotic fractures, and patients who are prone to osteoporosis, so patients with osteopenia. The multi-component exercises would mean the first is resistant training, so where all group of muscles should be trained at least twice a week. That's strengthening. Next is balance training. So balance training can be one leg standing, walking on a straight line. This is something that actually helps the proprioception baroreceptors, and that's 15 to 20 minutes a day. The third is lifestyle integrated exercises. So like getting up from your chair, telling somebody to get up and sit on the chair, telling somebody to hold the table and stand on one leg, telling somebody to just, like some patients having small hand weakness, you can just tell them to like make their rotis, so that even making the rotis is actually that something that helps them to coordinate. Writing is something that helps in coordination. So lifestyle integrated exercises works better, and aerobic training. The next is weight control. Generally, I don't tell weight loss because your body is used to a kind of weight that you always be. So weight control is something that's important. So an ideal weight, or the lowest weight which is in the last 5 years that the patient has, that should be the target. Next is nutrition. So D3 B12 supplements, they should be checked. A D3 once a month as a continuation dose, everybody should be taking. That's what we generally recommend. Calcium in osteoporotic patients, perimenopausal patients, and proteins at 1 gram per kg per day. So coming to treatment. So for severe pain, rest is the best medicine. We generally tell no stretching, no malishes or massages. The primary reason is that this is something that I just saw 2 weeks back. Somebody had pain in the back, and then they went for a massage, and then she stopped moving. She could not move her legs. She initially had some back pain, and she developed a neurodeficit. What we see here, this thing is an epidural hematoma that she developed because after a massage. So the kind of massage that patients go to, we don't know how much or how severe that's done, and developing an epidural hematoma, that because the bones are already weak, and developing a neurodeficit after massage, these patients are actually very difficult to be treated, and expecting a neuro recovery in them. So we know that there are 2 factors that comes into play. So the bone factory needs 2 things, that's calcium and vitamin D3. So when you give vitamin D3 and calcium to the factory, it starts producing bone. But what is there in osteoporotic patients is that the factory is not working. So even when we keep on giving them calcium and D3, the bone's actually not going to be formed. So we need to actually start the factory again for bone formation. So the raw materials are vitamins and calcium, but the factory starts with various anti-osteoporotic treatments like alendronates, that osteophos, Gemcal kits, denosumab, teriparatide, and calcitonin spray are something that actually helps them. And all of them need personalized treatment upon the kind of the exact scan that they have, the kind of complaints that they have, any history of fractures if they are. So this becomes treatment for osteoporosis per se. Coming to osteoporotic vertebral fractures. So when a patient with osteoporotic vertebral fracture like this is the X-ray. When some patient approaches you, how many of you would recommend rest? How many of you would recommend surgery? How many of you would recommend something else? So how many of you for rest? And if you answer, I also want to know how much of rest.
I think
If the
rest, but not the
fracture, if
prolonged
the
one, so that the pain subsides, and after that, the patient should be given isometric exercises.
Yeah, so generally, how much rest do you follow? What kind of protocol do you follow?
I think it's 2 to 3 weeks, not
2
more
3
than that.
weeks. So if a
Yes.
patient with these kind of X-rays comes to you walking, so what do you suggest in this kind of patient? Rest for 2 to 3 weeks.
No, if
Because most
patient is
of them,
coming walking,
as a physiotherapist, most of them would be coming to you walking with an X-ray that I have something like this. So what would you recommend to them?
if patient is coming walking, then I think they should go for isometric exercises.
Right.
Will
Then not the
gradually load it, like a progressive loading of the muscle, and slowly the bone will get habituated. I don't simultaneously the lifestyle has to be changed. Along with that, we'll train the muscles as you have discussed in before. Like we'll work on the endurance, muscle training
So any specific
simultaneously.
protocols that you follow before we take the discussion on it? So patient with osteoporotic fractures comes to you on day 1 week after his pain is less. But still he has pain when he gets up. He has some pain when he's turning in bed. And we send those patients as please do physiotherapy for this patient. So what protocols do you generally follow in your practice?
Yeah. when the patient comes, first we'll check for the mindset of the patient, whether he's uh, ready to do the movement or not. First thing, accordingly,
Right.
we'll educate the patient.
Right.
Secondly, we'll check for the muscle strength. Then we'll slowly, in my rehab, I'll slowly do this like progressive strength training. I'm doing so.
Okay. And what are the evaluating factors? So what are the factors that you look when you are strength training them? Yes, Dr. Preeti.
Sir, in this case, the vertebral height is almost it has lost by almost 60 to 70% or maybe more. The X-ray that you showed. So probably nowadays you all do that little procedure wherein you
Vertebroplasty.
fill in that material and increase the bone height because the patient is already mobile, walking, and depending on the age of the patient, that is also one option that can be given to the patient because he's lost almost more than 70% of the height of the bone. And then this compression, if it increases, then it can lead in future to a further complications.
Okay.
So and if the patient is not willing, then probably we can even consider, and if it's an acute history, then we can consider giving them a Taylor's brace and then continue with the rehab. Taylor's brace for at least 14 to 15 hours in a day, and then continue with all the exercises that one would, depending on the assessment, and then take it forward from there.
Okay. Okay. So this is what something that will follow. So somebody coming at 1 week with so much fracture, or more than 60% of height reduction is somewhere where you think, or I mean, where you discuss this option about vertebroplasty and then giving a Taylor's brace for a longer period of time. Okay. Anybody else with any other protocols?
I see most cases elderly with osteoporotic vertebral fractures who also have neurological issues, mostly like Parkinson's disease, diabetic neuropathies. So their falls are basically due to the underlying neurological condition.
Right.
So what I do normally is, even when I work with the orthopedic surgeon, we do not prescribe complete rest because when syndopa is on, we don't want complete bed rest. We want the movement also coming in. So if this fracture is stable, that is the vertebra has not collapsed, a brace helps during movement. And whenever there is no movement, we strictly advise lying flat because we want to minimize vertical stresses on the vertebral body, at least for the first 4 to 8 weeks. And in Bangalore these days, the new injections, right, the 90-day doses are used widely. So and that does give a lot of relief, and the progressive follow-up with X-rays definitely shows better bone mineralization. So it's a very, I feel, customized approach, understanding the underlying issues. But like others said, of course, progressive resistance, stabilization exercises, posterior chain training, balance training, all goes simultaneously, understanding the patient's level of endurance and the mindset to carry on these exercises.
Right. So I think that's a lot of good protocols that have been followed, and all of them are right in their own ways. So when a patient of these kind of fractures come to me, and if they are mobilized, I generally don't recommend complete rest to them. So generally rest helps for the first 2 weeks. By the time it's 2 weeks, most of the pain settled. And as you said, therapy that helps in most of these kind of patients. So most so this lady was given teriparatide, and you can see there's no bone here and this very beautiful bone formation here, and there was nothing else that was needed for her. We generally start mobilizing 2 to 3 weeks, start with isometric. The primary is the first thing is functional rehabilitation. We're getting out from bed, doing as much as they can by themselves. This is also kind of physiotherapy and optimization that the patient does. Then, so most of them are managed conservative with anti-osteoporotic medicines. Nowadays, there are very few who actually need only vertebroplasty. So clinically, as practicing spine surgeon, only vertebroplasty brackets are going down less and less because actually vertebroplasty they are stress risers to bones above and below. So patients who are older than 80 years, there's nothing that can be done. Vertebroplasty is something that we recommend. Most of them improve with anti-osteoporotics like say teriparatide, and severe patients with bone deficit, like one neuro deficit, is somebody where we consider surgery. So coming to principles of rehabilitation in these kinds of patients, prolonged rest is something that we do not advise. Out of bed as early as possible. Start with functional rehabilitation like getting out of bed, doing their daily activities, doing as much as they can, going to isometrics and functional rehabilitation. All of these within their pain range. So pain is something where for me is a caution, and we expect them that's gradually going to subside over 3 to 6 weeks. And strength training and back rehabilitation is done as and when the pain is tolerated. So it is divided into 4 phases. The first is acute phase, the subacute phase, the rehab phase, and the prevention phase. So coming to the acute phase is primarily aimed at pain relief. You can try modalities, various medicines, basic mobility like turning in bed, getting up from the bed, the way the patient should get up from the bed, avoiding any stiffnesses, avoiding DVTs, bed sores, and encouraging mobilization. This is the primary acute phase. Coming to the subacute phase, so after 2 to 3 weeks, when this acute phase is gone, the patient is almost in a pain range where the pain is tolerated and the patient does not need any pain medication for the pain. This is where we can describe as a subacute phase. So this subacute phase generally starts in the first 3 to 4 weeks. So mind you, not all patients with any osteoporotic fracture would turn up into a subacute phase at 3 to 4 weeks. A lot of patients with severe pain with a different kind of fracture may not come into this subacute phase, and those patients are somebody who would actually need deeper evaluation, consideration for surgery for pain if they do not have a neuro deficit. Again, it comes to functional rehabilitation, isometric, extensile strengthening. Then comes to rehab phase where the pain is gone, the patient is up and about, they can do their things as they want to do. It's 8 to 12 weeks. We go a little more aggressive on physiotherapy, anti-kyphotic exercises, postural training, muscle strengthening. And then is this preventive phase where all things we explain so that they don't have any other fracture. So upper limb strengthening comes into the play, ergonomic exercises. So all these are the 4 phases where exercise is generally recommended. So most patients are managed conservatively. However, not all. So this 60-year-old female fell from the bathroom. We all tried the first teriparatide for 3 months, but still she had severe pain. And why was this pain? Because as you see, when the moment the patient sits, as you said, that the moment there is weight bearing, there is complete collapse. So this is the fracture that we see here. And this is the fracture here. It's completely collapsed. So there is significant movement when the patient has this kind of pain. This is called dynamic instability. So these kinds of patients would actually respond less to conservative treatment, but it's only time that they can tell. So we generally give a trial of at least 3 months of conservative treatment if the pain is tolerated, if there's no neuro deficit, and that's when we actually considered even doing a vertebroplasty or a surgery. So here we did vertebroplasty and the patient was doing well. And similarly, there are patients who come with neuro deficit, so they are unable to walk. When this patient with neuro deficit come to us, primarily vertebroplasty is out of the box. So we don't consider isolated vertebroplasty for patients with neuro deficit. So because they have neuro deficit, that means there's some now compression that's going on, and we actually need to do a laminectomy and fixation. So these patients, this is her X-ray, would actually need a fixation and vertebroplasty, and that's what we generally do. So when it comes to post-surgery rehab, we generally consider that the acute and subacute phase is already gone. So they are out of pain, and the more aggressive we are, the more faster we expect the recovery to be. So it may vary from patients to patients how aggressive you can get, but we generally recommend that being aggressive helps us get faster. So most important part of recovery is post-surgery rehabilitation, early mobilization, functional weight training, stimulation to strengthen the muscle. Bracing does generally works if they have foot drops and lower limb braces as and when required. The tailor braces are not always well tolerated. If the patient can tolerate, then that's the best thing. If they cannot, then normal LS corsets are also fine in these kinds of patients. So just to conclude, a couple of take homes. Osteoporotic vertebral fracture, we always need to be suspicious. Osteoporosis is an or intrinsic problem of the bone. And so just treating the fracture does not treat the problem. It's very important that we treat osteoporosis per se, and just treating a fracture does not help us stop our treatment as doctors. We need to also come to this preventive role where we prevent the next fracture from happening. Most of the osteoporotic fractures are managed conservatively. So I'll say 80% of them are. Surgery is the option. In today's time and world, vertebroplasty is diminishing more and more. The reason being that with 10 to 15 years of vertebroplasty into play, we now see complications of vertebroplasty that are happening. There are adjacent ligament fractures happen because of vertebroplasty. So just remember, it's like a brick that's put in between cardboard boxes. So whenever there is pressure, the brick is going to fracture the box above and the box below. So we go more into fixations with vertebroplasty than going to just vertebroplasty. Early intervention in form of physiotherapy, in form of anti-osteoporotic medicines would mean better outcome. So it's time that we manage osteoporosis and get patients out of pain. So thank you so much.
Yeah, so Dr. Hriday, there are a couple of people who have raised their hands. So
Yes.
Yes.
And there are quite a question. So it'll be great if there have been a lot of them who have put up questions on the chat box. So it'd be great if you could ask them so that we can take the discussion ahead.
Sir, after
Yes,
Terry
doctor.
what the maintenance of the bone density, what needs to be taken for and for how long?
Yeah. So after a, can you please repeat? Sorry. After a fracture.
No, not after a fracture. In osteoporosis, if we give Terifrag to the patient for 18 months to 2 years, whatever is the maximum, what is done to maintain the density?
So currently in today's time, we have a total of 12 years of treatment that's there, 12 to 14 years of treatment for osteoporosis, which is there. So it will depend first on the age of the patient. So today, as per FDA approval, you can actually give teriparatide for 30 months, that's 2.5 years. You can give osteoporosis alendronates for a period of 4 years, and then there are denosumab that you can give for a period of 10 years. So a total of almost 14 years of treatment is something that we have. In patients with fracture, we generally give teriparatide for a year and keep it reserved for later life. We generally switch them to any other form of anti-osteoporotic like denosumab or risendonate, alendronate kind of bisphosphonates. To carry those on for 2 to 3 years, check the BMD every yearly. If we feel that the BMD is either increasing a bit or is stable, we give a anti-osteoporotic free period for 6 months to 1 year. We recheck them and then we switch them to any other form of anti-osteoporotic. So it's buying time and catering based on the time when the patient presented, the kind of symptoms that they have, and years of life that we expect. So we expect somebody to generally live for 75 to 80 years. So depending, if a patient with a 45-year-old osteoporotic fracture comes to us, that's very different because we need to carry at least take another 35 years in his life with a 12-year of medicine. So there are more periods of treatment-free intervals that we give. Whereas the 70-year-old patient coming to us, we may not give a treatment-free interval if not needed.
Can Terifrag and Olimab can be given together in severe osteoporosis?
Yes, of course. Terifrag, Olimab, there's one more anti-osteoporotic that has come up, is called rivasumab. It's once a month medicine, is as effective as a teriparatide, and it's a monoclonal antibody. The only problem with Olimab that no companies describe is that it has a very severe form of rebound osteoporosis. So you cannot stop Olimab and not transfer them to any other form of anti-osteoporotic. So if you stop Olimab, you have to give any other form of osteoporotic medicine. Otherwise, the patient will have rebound osteoporosis.
Sir, I have a couple of questions.
Yes.
You had mentioned about that instability pain
Right.
in your beginning slides. So that pain is when the patient is not able to turn in the bed. That is only what you describe with instability pain or anything more?
So instability pain. So instability pain is something that the patient has in any change in position. So what? So simplify that. Just understand that the bones are like hinges on a door, and the moment a hinge breaks, the door is going. It is going to be very difficult for the door to open and close. So just imagine that if one of the bones fractures, so any form of movement, like turning in the bed, getting up from the bed, sitting up from lying down position, sudden change in posture. So all these are classified as instability pain. And these are very important clinical sign of fracture. Nobody is going to complain just sitting at home that I have pain turning in bed and for me, clinical and history taking is the most important thing, even more important than an X-ray or an MRI.
Okay. So, sir, these are the initial things that we can pick up also from the history from the
Yes. So
patient.
that's what. So when a patient has been following up on you for some generalized back pain, and when the patient says that recently I have this kind of pain, that's something unusual. So most patients understand more than what we do. That's what I believe, because it's their body.
Yeah.
They understand their body more than what we as physicians could actually understand. So if they tell you that there is some severe form of pain, we need to respect that symptoms and investigate that further.
Yeah. And sir, you mentioned about the T score and the Z score, sir. So,
Right.
which one should we give importance to?
So as per definition, it's Z score, but because of age, what we see is T score, because that's what actually defines treatment.
Okay. And sir, if we see just osteopenia in the radius, is it to be given as much importance?
So that's what I said. So there's three things that we do: radius, hip, and wrist. The worst is what we consider.
Yeah,
If
but
there's
generally they say
osteopenia, all
that
the
the
three.
radius
If
is not a
there's
weight-bearing bone.
But still, so that's what you need to consider is these three bones are representing the entire body. There are three people that they are representing the company. If one of them is bad, that means there's 33% of the company is going bad. That's what. So if there is osteoporosis in one bone and osteopenia in the other two, that means we do treat them as osteoporosis. If there's osteopenia in all the three, so just having something in the radius and the hip and the spine being normal, that would, so the worst has to be considered.
Acha, because here some doctors they say if it's in radius, they really don't pay much attention to. Only in the hip and the spine, if it is there, only then the treatment needs to be initiated, because they say that the radius is a non-weight bearing bone. So in any case, it would be. This is what the
But so
opinion
that-
of some
so-
people is.
Yeah. So, but the thing is that wrist, hip, and spine, so that those bones are actually evaluated because they are the most superficial bones and they're most prone to osteoporosis. So if the hip and the wrist, if the hip and the spine has osteoporosis and the wrist does not have osteoporosis, that does not mean we do not treat osteoporosis. If the wrist has osteoporosis and if the hip and the spine does not have osteoporosis, that again does not mean that we don't treat osteoporosis.
Acha. Okay.
Because the chances of fractures are the same. Somebody falling on an outstretched hand or somebody falling in the bathroom will have more chance of a wrist fracture because the patient has a osteoporotic fracture. What for me, even a little toe fracture comes into the classification of osteoporotic fractures, and generally we explain to them that they would need a BMD evaluation yearly because we don't need to wait for fractures to happen. In today's time and world, it's more about prevention rather than treatment that we're looking at.
Sure. Sir, a lot of time we have ladies who are, or our relatives also, they said that should we just start with calcium tablets after the age of 40? Is it to be routinely started or only
So
after the
what I
evaluation
recommend is
BM?
rather than age, we should consider menopause as one of the signs. If the patient who is perimenopausal should start, there's nothing wrong in doing that.
Sir, but excess calcium would not cause any problem in the long run?
So a lot of them think that calcium will cause kidney stones. But
that's yes, exactly.
Yeah, so they don't do. So there are various components that are available. So that's calcium citrate malate, CCM. The various form of, there are various components like calcium citrate, calcium carbonate, calcium citrate malate. So calcium citrate and calcium citrate malate are generally not prone to cause kidney stones.
Kidney stones. Okay.
Yes.
And sir, one last question is, in case if somebody who is in the 50s and who is female, just menopaused about a year ago or so, and is diagnosed with osteoporosis, but there is no, and the FREX score is also low, and also there is no other history, and no aches, pains, nothing. I mean, the doctors have said there is no treatment at the most needed except for the calcium supplements. So is this, sir, this condition can be reversed in any way?
So first is how do you diagnose the patient with osteoporosis?
Just on DEXA scan.
So then it depends on the value of DEXA scan. So a lot of patients are fit 55s, a lot of them are not fit 55. So a 55-year-old patient with no complaints, just doing a DEXA scan for a routine evaluation, like a lot of hospitals do DEXA scan as their routine body checkup thing. So
Nowadays, in all the body checkups, people include that
exactly.
also.
Good DEXA scan. So if they have been diagnosed with DEXA scan on the first instance at the age of 55 with no complaints, then calcium D3. Tell them to wait for a year, repeat the DEXA scan and see if it's worsening. If it's not, then we don't do anything. If it is, then we may need to consider, and this has to be discussed with the patient. Because we are starting this treatment at this age so that you don't have a fracture. If you don't want to take the medicines, you're free not to take it. But calcium
But
D3
in
we do
any
recommend.
case, would it be reversible in partially
Reversible, also? So reversible, I don't think there is a definition of reversible. So you see 10 to 20% improvement in the DEXA scores with anti-osteoporotic treatment. You cannot go from osteoporosis to osteopenia unless it's done at a different center. So different centers give you different values of DEXA scan. So if it's done at a center A, it shows osteoporosis, and a center B shows osteopenia. That does not mean that their osteoporosis has been reversed. But being reversible it's like more like a relative term. The primary aim becomes to avoid worsening rather than reversing
it? So at the most, you may see some 10% or 20% change in the DEXA score value, even if done at the same center.
So that's not my idea of treatment, first of all. So DEXA scan is not the idea of treatment. So being reversible are always, so as far as spine general is concerned, so when it comes to any complaints, can be stenosis, can be a disc, it can be osteoporotic fractures or osteoporosis per se, treatment would always come out as a patient specific complaints. Are they improving or not as a report specific that the DEXA is improving or not. For me, if the DEXA is the same and the patient is improved, that means that the patient is improving. It may not always take 1 year for the DEXA to improve. The DEXA may not improve because it's been worsening and we are actually holding it at that particular level. That means it's still improving. So for something that's already decreasing and we are keeping it steady, that means it's improving for us. The patient may not understand that, but yes, it's improving because it's not going negative. So improvement as far as osteoporosis is concerned is always symptomatic and not report based.
True. And sir, why is sarcopenia associated with osteoporosis? Is it just because of age or because of the hormonal changes also?
Both of them. So it's a process where it's normal degenerative process because of disease atrophy is what generally happens. They do improve with time because muscles generally take only 3 weeks for an atrophy to start.
True.
So it's both.
Thank you so much, sir.
Thank you.
2 more questions, sir. Please, in these days, calcium preparations are available with vitamin K2. What is the use of that?
They are for joints, generally. K27 and stuff is for joints. Not for spine.
Okay. Most of the time, doctors say that penetration of the calcium is more with vitamin K2, so it should be taken in patients with osteoporosis.
It's still a DC-DIC thing. K27 does help, but primary for an osteoporotic patients, we generally think to improve penetration per se, anti-osteoporotic medicines work better. All these are not something that would actually, penetration 5-10% it can increase, but not greatly. I generally I give plain calcium in my practice.
And what will be the indication of calcitonin nasal spray as
so calcitonin nasal spray primary for pain. So calcitonin nasal spray is primary for pain. Early patients with pain for a very short duration is what we give. There are reports coming up that they do cause sarcomas. So there are reports in European journals that say that long use of calcitonin sprays cause sarcomas. So we do use it with caution, but only for early first couple of weeks after an osteoporotic fracture for osteoporotic pains.
Right. Thank you, sir. Thank you.
So we have a couple of questions on the chat box. If somebody else has questions to ask, Dr. Vishal has again raised his hand.
Yes, but we'll continue with the questions in the chat for now. And by that time, if he's available, we'll be assisting with the answers.
So I'll go from back up so that I don't need to slide the reverse end. So there's one question by Dr. Deepti that what to do in case of osteophyte in the back. We don't need to do anything because there are degenerative changes on the X-ray. So basic back strengthening isometric exercise is what you follow should work. If there is anything, please unmute and answer, or if you want to discuss the same question further.
The role of denosumab in carcinomatous metastasis?
In
bone metastasis, role
so
of monoclonal
yes.
antibodies, denosumab.
But so the role of denosumab in metastasis. So this is a very wide question. It depends on the kind of metastasis that the patient has. A lot of time for primary tumors, denosumab has been used, especially because it is bone forming antibody. It is used in a very different dose. But for metastasis, it depends. Post treatment for metastasis to prevent fractures, quite often it can be used, but it depends on the type of metastasis that the patient has.
That patient, she had treated for carcinoma breast, and they've done the DEXA scan. They don't have no specific lesions, but on a preventive measure, they have advised. Is it how often
Can take, because teriparatide is generally contraindicated when it comes to tumors. So denosumab is one of the very safe medicines, so it can be taken, but it's still off the counter indication. Like there are no proven indications, but some of them may use it because in their practice they would have seen results.
Oh, in those patients, teriparatide they will
No,
not work.
we generally don't give because teriparatide are generally contraindicated when there are tumors. So if patient has metastasis, that means their patient has active tumors. So generally we don't recommend teriparatide in active tumors.
Okay, denosumab or any other alternative for those patients?
Denosumab can be given because the safer medicine. If the patient is on all other medicines, they can be taken. So denosumab should be some.
Okay. Thank you.
So there is one question by Dr. Ashwini that how will you differentiate wedge compression fracture from osteoporotic fracture on an X-ray, and what will teriparatide if given for months cause any complications? So wedge fractures and osteoporotic fractures can primarily be differentiated, number one, by history, and MRI can help. Unless proven otherwise, most of patients with old age and cerebral trauma are considered as an osteoporotic fracture. Wedge compression fracture is the type of fracture on an X-ray. Osteoporotic fracture is a physiological classification. So, a osteoporotic fracture can be a wedge compression fracture. So, patient suffering from hypertension diagnosed osteoporosis, then in this case, can use osteoporotic treatment. Yes, there's no confounding between hypertension, diabetes, and osteoporosis. You can treat them as general osteoporotic patients.
Sir, I have put one question in the chat. If you can look into it.
Can you please, since you're unmuted, can you please ask them directly?
Yes, yeah, sure. So, sir, in osteoporotic, like people who are 75 and above and who are diagnosed with osteoporosis, is 1000 mg of calcium recommended?
Yeah, so that is the recommended dose. It also depends on tolerated. So a lot of patients may not tolerate 1000 mg of calcium. You need to gradually increase the amount of calcium that you give. So 1000 mg of calcium is actually a recommended dose when it comes to osteoporosis in elderly. It cannot.
And in the age group of between 50, 60s also, sir.
Sorry.
In the age group of 50s and 60s also, sir, 1000 mg can be given to the patient.
Can be given, yes, can be given, but it depends on toleration primarily.
And sir, in people who have calcification in the tendons and all, would it cause any problems with this calcium tablets that the patients take? That's a common concern that I get in my patients.
Yeah. So primarily the reason of calcification of tendons or calcific tendinitis is enthesiopathy. Why do calcification happen? Calcification happens because there is extra pull on that particular bone when the muscles act, and that is what causes calcific tendinitis. Yes. Calcium in the bones or calcium in the blood does not have any correlation.
Yes, that's what we explain to them, but people have their inhibitions from taking calcium. Yeah. And they say it will cause calcification in my heart also. Sir, is there any correlation with that?
There's no answer to that. You try and explain as much as you can.
So, sir, it's okay to take, na? Even if people who have calcification in the heart.
Yes. In the heart.
Because it is the thickening of the walls, which actually.
Yeah. So there are a couple of vague generic terms that patients use that has no relation with science. So like calcification in the heart, that does not have any relationship with what science has. Calcium treatment, calcification in the heart would actually mean clots are because of cholesterol, not because of calcium. So they can take.
Sir, excess calcium.
CCM. Sorry.
Sir, excess
Yeah.
calcium which people take, like even people just start nowadays for preventions. So they start taking 500,000 mgs on their own. Would it really cause problems to them in
So,
future,
as I
sir?
said, it depends on the kind of component that the patient is taking. So, I cannot deny that calcium can cause kidney stones. Yes, it depends on the what component that patient takes. A lot of them are available over the counter. So, it would actually depend on the type of preparations that take. Anything is excess is always not good. But it depends on what patient takes,
So
how
you say
frequently they
CCM
take.
is quite safe that way, sir. CCM
Calcium, yes, most of them are like citrate malate is even very good, well tolerated.
and calcium carbonate also, sir.
Yeah, actually, sorry to interrupt. We have a couple of questions lined up, and as we are lacking
Sure,
time, we
sure.
can definitely connect post meeting. We will
Yeah, I have
be
given my
sharing the
number, so
contacts.
you can
Yeah,
share.
as we have a couple of more questions lined up, and also we are lagging time. Yeah, so we have a question from Dr. Harikesh that patient suffering from hypertension and diagnosis osteoporosis, and in
Yeah,
that
I
case,
answered that. I answered that,
okay,
that you can take anything. Then,
okay.
what is the role of calcium and D3 supplements? Calcium and D3 supplements are to be given because only bone formation cannot happen with anti-osteoporotic. Calcium and D3 are primary raw materials that has to be supplemented. Is there any range of T-score and Z-score where olimab injection is prescribed? So olimab, so denosumab, alendronates, all of them work in the same way. They are anti-resorptive. So they are medicines that actually prevent bone from uh, degeneration or causing osteoporosis. They are not the ones that actually form bones. So teriparatide is one injection that forms bones. So olimab, alendronate, all of them are first-line treatment when it comes to osteoporosis. So anything less than 2.5 with symptoms, you can start.
Yeah, so mostly all the questions are covered, and it was, yeah, way much insightful session that we had expected, and the audience was also quite active and interactive. So yeah, thank you so much, Dr. Hriday.
So thank you all. Thank you all for being so interactive. That actually helps us get this session even better and keeps us inclined to more of such webinars.
Definitely, definitely.
I think before we end, Dr. Savita has a question.
Sorry, doctor, I got late. I was attending a client. My query is actually most of the time I push whenever I feel there is some doubt about osteoporosis when they come for physios for back pain or other pains. So generally I push them for bone mass density. Once they know that there is osteoporosis and they go for the consultation and they'll be given injections. What happens is when post injection they get so much side effect of the injections like vomiting, and 2-3 days they'll be totally fatigued, or some
Which
patients have for a
injections do
week.
they give?
Oh,
This osteoporosis में lecture चल रहा है. Osteoporosis में
Zoledronate.
webinar चल रहा है.
so if they generally what happened, they get little worried about
So
that
yeah, so
whether to
what?
continue this monthly injection or any yearly injections like.
So yeah, so the yearly injections which they take, they are generally zoledronate, IV
Mhm.
zoledronates. I generally don't
Yeah,
recommend
I
them because we have oral options that are available that work in the same way. Zoledronates have these kind of reactions like they are called allergic reactions. Actually, they have vomiting, they may have rash, they may have fever. So this is a very normal thing. There are options like alendronate that are oral that are available, so they work in the same way. So they can take, nothing to worry.
Yeah, generally they know they try to avoid the
But they
further
can.
dosages.
There's nothing to worry about.
So I mean, along with the medication, do you advise any to prevent the side effects
There's
like if
nothing
they
that
have
you can do.
vomiting,
They are drugs.
anti-vomiting?
They are drug reactions. You cannot do anything. You can either take
Okay.
an anti-allergic, but they are called drug reactions. That happen when you take a drug.
Okay, thank you. And one more question. And I have some patients, some who are, I mean, genetically having the strong for cancer, and their sibling then or the next generation when they want. Is it a better option as a postmenopausal for them to first go for an hormonal line of therapies, or better to go for these osteopenic
So yeah,
treatments?
so This is a very good question because now hormonal treatment for osteoporotic are actually resurging. So there was a time when hormonal treatment for osteoporosis was not prescribed. Now gynecologists do prescribe them. There are good estrogen patches that are available that actually help relieve symptoms of osteoporosis. Osteoporosis and osteopenia may not only have bone-related symptoms. There are many perimenopausal symptoms that patients have, and hormone therapy actually helps them. So I, especially as an orthopedic spine surgeon, do not prescribe them, but gynecologists do prescribe them. So I have my wife who is a gynae who prescribes them.
Sir, is it safe if they have a susceptibility?
Yeah. So it being safe or not, I am not the right person to answer it. But if a gynecologist feel it's safe with the kind of patient profile they have, they can be given. And there's a resurgence of the hormonal treatment in the recent times.
Okay. Sir, as an ortho surgeon, I mean, do you prefer them to go for hormonal replacements before beginning these?
Yeah, initially, of course, why not? If they fall into that category, why not?
Okay. Thank you. Thank you, sir.
Sir, any role of injection Metadec and all anabolic injections sometimes people prescribe. Is it beneficial? But people are telling well-being after injection.
Sorry, what
Metadec
kind of
injections, sir. Metadec.
So I'm not much aware about that. For me, anabolic injections are teriparatide.
Anabolic injections.
Yeah. So teriparatide, something that actually works in the same manner. So instead of giving them anabolics, I generally prefer teriparatide.
Sir, in the starting but it's only symptomatic. Blood reports are not showing that much of. In those cases, we can give teriparatide.
Teriparatide was safe. So for mild cases, we generally don't recommend.
Okay, we can safely give, but
yeah, giving it safely is okay, but it's not indicated. That's it.
Okay, sir. Out of the nasal spray and injectable, which is better?
Both of them work in a very different way. So nasal spray is not to prevent osteoporosis.
Okay.
I think we have two questions in the chat.
Yeah, so for Dr. Mithilesh Gupta, any form of calcium supplement is okay. Is PCOS patient prone to osteoporosis? It depends on the irregularity of periods and when do they develop, because they do have hormones in them. They are just not cycled correctly. So they cannot be considered prone to osteoporosis, but if the periods end early, that would categorize them into early menopausal patients, then they are. You cannot have generalized PCOS patient as prone to osteoporosis.
I think we have covered all the questions. Thank you, everyone. Thank you, Dr. Acharya, for spending some time with us and answering all the questions of the physiotherapist. This was really useful and your practical inputs were quite good. Thank you, everyone. We will be sharing a feedback form today. We hope to receive some inputs from you so that we can align our next webinars accordingly. Thank you, everyone.
Thank you, Physio Plus, for this great webinar.
Thank you so much.